Okay, so let's move into obstructive lung disease. So chronic obstructive lung disease is a nonspecific term which includes a number of conditions which we'll talk about. So there's asthma, chronic bronchitis, emphysema, and bronchiectasis. So I know you're familiar with all of these entities from the lab, so that will be helpful as we go through them. Just something to note here is that chronic bronchitis and emphysema, although we talk about them as separate entities, which they are highly associated with smoking, both of them. So they're often grouped together clinically as chronic obstructive pulmonary disease, or COPD, because many patients who smoke have elements of both of these things. So the common features of the obstructive lung diseases are shortness of breath, a chronic airflow obstruction, and a decreased forced expiratory volume because of that obstruction. I think something that's helpful to kind of classify these is to compare obstructive versus restrictive lung diseases. So we just finished our portion on restrictive lung disease, which we saw was primarily a parenchymal disorder, whereas in obstructive disease, it's typically an airway disorder. In restrictive lung disease, we see the decreased ability to expand the lungs properly, as well as a reduced total lung capacity for that reason, and decreased diffusion capacity of gases. And so in obstructive, we see increased resistance to airflow and limited expiratory rates because of the obstruction. And so that manifests on pulmonary function testing as a reduced FEV1 to FVC ratio, whereas as we mentioned before, although the FEV1 and FVC are both reduced in restrictive disease, the ratio is normal because they're proportionally reduced. So in obstructive lung disease, we see that the FVC is reduced, and the ratio of FEV1, so the flow in 1 second over the FVC ratio is usually less than 70% of normal, whereas the FVC is usually less than 80% of normal by definition. So in our chronic obstructive lung diseases, the obstruction is due to something limiting airflow. So in asthma, this is a narrowing of the airways, which is reversible. So that's a key point in differentiating these disorders. You have a reversible airway obstruction in asthma. And in chronic bronchitis, emphysema, and bronchiectasis, there's this loss of elastic recoil, and then you have obstruction secondary to collapse of those airways, and it's irreversible. So when we talk about emphysema, it's helpful just to define what it is to begin with. And Robbins defines emphysema as an abnormal permanent airspace enlargement distal to the terminal bronchioles, and this is accompanied by destruction of the airspace walls without fibrosis. So there are a few different types of emphysema, and we'll focus on a couple of these types. The first is centroacinar, and so this is the type of emphysema that we typically see in smokers. So in centroacinar emphysema, it's the central part of the acini that are affected. So mostly the respiratory bronchioles. So your distal alveoli, so distal to those respiratory bronchioles, are unaffected. There's typically an upper lobe accentuation, particularly at the apices of the lungs. But if this gets to a more severe stage, your distal alveoli can also become involved, not just your respiratory bronchioles. and then it will have a more pan-acinar type of picture, which is another type of emphysema that we'll talk about next. But this is typically seen in heavy smokers, and of course it's associated with chronic bronchitis because those are both smoking-related entities. In the pan-acinar type, it's not just the respiratory bronchioles that are affected, it's also the alveoli that are distal to that. So that's pan-acinar, affects the entire acini. It's more common in the lower lung zones and most severe at the bases of the lungs. And this form, pan-acinar, is associated with alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin is an antiprotease. So trypsin is a protease, it breaks down proteins, and under normal circumstances, we have antiproteases that can be produced to dampen the effect of proteases and prevent them from causing destruction of your normal tissues. But in patients who have a genetic deficiency of alpha-1 antitrypsin, they're not going to be able to shut down that protease-mediated destruction. And so we see damage to the entire acini. Paraseptal emphysema, so has a different pattern. It affects the distal part of the acinus. So it doesn't affect the respiratory bronchioles. This is typically seen adjacent to scars in the lung or areas of fibrosis or atelectasis. It's predominantly seen along the pleura or the margins of lobules. And where this comes into play clinically is often in young patients that have spontaneous pneumothoraces. So often these are young patients that smoke, and they'll just come in with a spontaneous pneumothorax. And it's thought that it's probably due to this paraseptal emphysema. They'll eventually form these bullae, or kind of cyst-like spaces at the pleura, and if those perforate, then the result is pneumothorax. And then we have irregular emphysema. So this is associated with scarring as well. This is thought to be common, but is clinically insignificant. So it doesn't cause any significant clinical disease. So if we look at a couple of diagrams that compare the centroacinar versus panacinar type of emphysema. So in the centroacinar, again, this is the type that we would see mostly in smokers. So we see the respiratory bronchioles being affected. So we see enlargement of those central air spaces, but the more distal air spaces are spared. Now, if this gets worse, as it can eventually look like this panacinar emphysema, which is a type that we see in those alpha-1 antitrypsin deficient individuals, where we see the entire acinus affected. So we see this cystically enlarged air spaces involving the entire acinus. So I think because of the clues that have been gathered with patients that have alpha-1 antitrypsin deficiency, it's thought that at least a theory has been put forward that it's this protease versus anti-protease mechanism. Again, because these alpha-1 antitrypsin patients are susceptible to panacinar emphysema. Alpha-1 antitrypsin has this anti-elastase activity, and we know that the airways are elastic. They need to be able to have that sort of ability to squeeze the air out, if you will. And if you lose that elastic tissue, you lose that ability, and you're going to be left with air trapped in those alveolar spaces, and an inability to have gas exchange in those affected air spaces. Some other evidence has been shown in animal experiments where elastases that have been instilled into lungs have been shown to cause emphysema. And then we know that neutrophils and macrophages both can produce and secrete elastases that under normal circumstances will be inhibited by alpha-1 antitrypsin. However, if these are activated, they can also produce free radicals that can inhibit alpha-1 antitrypsin activity. So it's thought that perhaps in the smoking situation, some of the toxic molecules in smoke will result in increased free radicals, as well as eliciting inflammation that can also elicit free radicals and inhibit this alpha-1 antitrypsin activity, leading to the emphysema. So again, smoking reduces these anti-elastases, as well as increasing elastase activity. And because the smoke is most often going to be present in those respiratory bronchioles as opposed to the distal airways, it's thought that the effect is more toxic, and that's why we get that more centroacinar type of distribution. So again, centroacinar distribution in smokers, likely reflecting the impact of the smoke at that bifurcation of the respiratory bronchioles. And the upper lobe distribution that we see in emphysema associated with smoking is thought to be possibly due to reduced alpha-1 antitrypsin availability, because those lung fields are not perfused as much as the lower lung fields because of the effect of gravity. And in the panacinar version of emphysema, at least in alpha-1 antitrypsin deficient individuals, is reflective of the total lack of antiproteases throughout the entire acinus, and that lower lobe predominance that we see in those patients is probably due to greater perfusion and greater neutrophil numbers in the lower lung fields. So when we look at lungs from an emphysematous patient, what do we see? The lungs are typically hyperinflated, and they may show formation of bulla, which are basically enlarged cystic spaces. And the parenchyma can have this moth-eaten appearance where we're seeing this irregular areas that are showing these cystically dilated air spaces. We have destruction of the alveolar septa without fibrosis. So you get these free-floating alveolar septa and just these enlarged air spaces. And I'll show you a picture of that. And then in the small airways, we have destruction of your elastic tissue. So this contributes to the airway obstruction when trying to exhale because of airway collapse. So here's a picture showing a typical centroacinar type of emphysema, and we can see that there's this accentuation in the upper lobe, so it's not nearly as prominent in the lower lobe. We're seeing these cystically dilated air spaces, formation of bulla, so these are these enlarged cystic spaces, and there is surrounding more normal appearing lung parenchyma. So that's the centroacinar picture. Higher power shot, again showing these cystically dilated air spaces, but also areas of more normal looking lung parenchyma. In the histologic correlate, what we see here are these cystically dilated air spaces. So we're seeing these all over, as well as some more normal appearing smaller air spaces. So it's really affecting that, just those respiratory bronchioles. And we have our distal alveoli maintaining their structure. In contrast, in panacinar emphysema, we can see that the entire lung looks abnormal. We're not seeing any normal areas of parenchyma. It's just these cystically dilated spaces diffusely seen throughout the lung. Higher power shot showing all of those cystically dilated spaces, no normal looking lung parenchyma. And then these greatly enlarged cystically dilated air spaces. Again, in emphysema, there can be formation of bullae, and these are often adjacent to the pleura, so we can see these enlarged cystic spaces. These can perforate and result in pneumothorax in many patients with smoking-related emphysema. So that may require surgery to remove these portions of the lung that have these bullae to prevent further or recurrent pneumothoraces from occurring. So the clinical course of emphysema, so basically before clinical manifestations are seen, you require damage to about a third of the lung parenchyma. And once this happens, we see progressive dyspnea. There's variable cough or sputum production, and that's going to depend on the associated chronic bronchitis. Weight loss. We see the so-called barrel chest. Because of that air trapping, your lungs are typically hyperinflated, and over time results in this barrel-like chest compared to normal. Pursed lip breathing, and of course expiratory airflow limitation on spirometry. So there's a couple of terms that have been given to those patients that have emphysema without chronic bronchitis versus those that have chronic bronchitis associated with their emphysema. And the first is those with chronic bronchitis. They often have recurrent infections with purulent sputum. They often have hypoxemia and hypercapnia. And because of that, they have this cyanotic appearance, and they, for whatever reason, it's not really known, they often are a little bit more obese than the other type, and so they've called these patients blue bloaters. Whereas those with primarily emphysema without the chronic bronchitis, while they still have a decreased diffusion capacity, they do have normal blood gas levels and less of a perfusion ventilation mismatch due to hyperventilation. So they have more of a respiratory drive. They don't have the cyanotic appearance that the blue bloaters have. And so these have been called pink puffers. And so here's your typical pink puffer versus your blue bloater. So what about chronic bronchitis? So this is a clinical defined entity. So chronic bronchitis is defined as cough that's productive of sputum for greater or equal to 3 consecutive months in greater or equal to 2 consecutive years. And so there can be this simple or mucopurulent chronic bronchitis, which is patients that have a productive cough that fits this definition but don't have evidence of airway obstruction. Then there's a version called chronic asthmatic bronchitis. These are patients that have intermittent bronchospasm, and because of that intermittent narrowing of the airways can produce a wheeze, and hence the term chronic asthmatic bronchitis. And then obstructive chronic bronchitis. So these are patients that have chronic airway obstruction. Usually they're your heavy smokers. So chronic bronchitis can be due to smoking, would be the most common cause, but also just exposure to toxic chemicals that you see in smog-laden cities, and as we mentioned earlier, often occurs in conjunction with emphysema when seen in smokers. So the pathogenesis of chronic bronchitis is chronic irritation of airways due to inhaled irritants. So mostly smoking, but also could be grain, silica, cotton, some examples. Infections can trigger acute exacerbations of chronic bronchitis. So you basically just have this superimposed infection on top of the chronic bronchitis. Hypersecretion of mucus is the earliest feature that's seen, and also the main feature. And this is due to hypertrophy of the submucosal mucus-producing glands in the trachea and bronchi. And then in your smaller airways, you have an increase in goblet cells, so goblet cell metaplasia. So that's thought to result as a reaction to those irritants. So just this production of more mucus to kind of counteract the effects of those irritants. So the airflow obstruction mostly results from mucus hypersecretion in smaller airways. But we also see an inflammatory infiltrate as well as clustering of alveolar macrophages in air spaces, fibrosis of bronchiolar walls, and of course, if there's coexisting emphysema present, it's going to increase the impairment. And so if there is emphysema present, it's usually the dominant lesion in COPD. If there is a coexistent infection, it's secondary, but obviously can complicate things and exacerbate symptoms and may require antibiotic treatment and hospitalization in some cases. So the morphology of chronic bronchitis, as well as the histology, is variable, but we can see hyperemic and swollen large airways with, of course, mucinous or mucopurulent secretions, and these can cause mucus plugging. In the large airways, there's hypertrophy and hyperplasia of the seromucinous glands, and I know there's a nice picture in your tutorial showing that. And sometimes you can use what's called the Reed index, which I'll show you on the next slide, which is a measurement of how much those glands are hypertrophied. You may see some inflammatory cells as well. In the smaller airways, we see that goblet cell metaplasia, as well as mucus plugging, inflammation, and fibrosis. So here's an example of seromucous gland hyperplasia. So we see this increased thickness of the seromucinous glands. And here's the goblet cell hyperplasia that's seen in some of the smaller airways. So all of these large cells are your goblet cells, and they produce mucus. And then the Reed index is the ratio of the thickness of this mucus gland layer to the thickness of the entire wall between the epithelial layer shown here and the cartilage. So just a chart which tries to distinguish characteristics of chronic bronchitis versus emphysema, but can be difficult because these are seen often in the same patients. So there are some age differences. Chronic bronchitis seen often earlier than emphysema. Dyspnea is often mild and occurring late in disease in chronic bronchitis, whereas in emphysema, dyspnea is usually severe and occurs early in disease. So once emphysema is there, the dyspnea is there. In terms of cough, we see the cough early in chronic bronchitis, and of course the definition of chronic bronchitis includes cough that's productive of sputum, so you need to see this. In emphysema, cough happens late, and usually there's just scanty sputum that's produced. Infections will commonly exacerbate chronic bronchitis, whereas they're only seen occasionally in emphysema. Respiratory insufficiency is seen repeatedly in chronic bronchitis and in the terminal phase of emphysema. Cor pulmonale would be a common feature in chronic bronchitis, but is only rarely seen in isolated emphysema at end-stage disease. Airway resistance is increased in chronic bronchitis, but is usually normal or only slightly increased in emphysema. Of course, the elastic recoil is very low in emphysema because we're destroying that elastic tissue in the airways, but is normal in chronic bronchitis. Chest radiography, in chronic bronchitis, there may be prominent vessels seen and an enlarged heart, whereas in emphysema, we see hyperinflation because of that air trapping. And then, again, we mentioned earlier the appearance of the blue bloater in chronic bronchitis versus pink puffer in emphysema. Okay, so we're going to switch gears now and talk about another one of the obstructive diseases, this time with reversible airway obstruction, asthma. So, as you know, this is a very common disorder. Between 100 and 150 million people suffer from asthma worldwide. And the prevalence rates of asthma are increasing, so about 50% per year, which is interesting. Classification of asthma is difficult because attempts to classify asthma, as I'll show you, have a lot of overlap between them, so it is difficult to sort of put asthma into well-defined categories. But it has been attempted to sort of classify different types of asthma into an extrinsic type. So this is thought to be a type 1 hypersensitivity reaction that's driven by an extrinsic antigen. So this is also known as atopic asthma. And then the intrinsic type is that those types of asthma that are driven by non-immune mechanisms. And so there's no type 1 hypersensitivity reaction per se. So a drug effect, infections causing asthma, especially viral infections, cold air, or occupational exposures. But because of the marked overlap between these two classifications, many don't consider this to really be a valid classification. But just be aware of it. So asthma is an inflammatory disease of the airway and is characterized by episodic attacks of this reversible bronchoconstriction. So you have these hyperactive airways that, upon triggering, can basically close down. These airways have increased responsiveness to various stimuli, so whatever the particular trigger or triggers are for an individual with asthma. And we see obstruction, which is more often during expiration, and that causes the wheeze. That is characteristic of asthma. The FEV1 is markedly reduced, less than 30% of normal. So real difficulty getting that air out because of the constriction of those airways. And so there's hyperventilation, so there's this drive to breathe as much as possible. There's hypoxia, hypercapnia, and respiratory acidosis that results from the airway obstruction. Patients will have symptom-free intervals, but during those times where they are symptom-free, there often still is a respiratory defect on spirometry. And then status asthmaticus is a severe, prolonged asthma attack, basically, that's unresponsive or refractory to therapy. So clinical features, we see recurrent sudden attacks of respiratory distress, tightness of the chest. Patients will have expiratory dyspnea, so trouble getting that air out, wheezing. There's rhonchi may be heard due to the copous mucus secretion that can occur. You can have this thick sputum, and then progressive hyperinflation of lungs because air is being trapped in the airways that are distal to the mucus-packed bronchi. It's often episodic, so often nights and early mornings we see attacks happen more frequently. They typically will last a couple hours and then either subside spontaneously or with therapy by bronchodilators largely. So some common triggers, an allergen, so whatever an allergen happens to be in a given individual, cold or heat, infections, exercise can induce asthma attacks, emotional stress, and then other causes or unknown causes. What we see is inflammation of the airways. This is a type 1 IgE-mediated hypersensitivity reaction. And so we'll show some pictures that show the typical sort of inflammatory infiltrate that we'll see, and abnormal narrowing of the airway. So there are some risk factors for asthma. So if there's a family history of allergy, any other allergic disorders, if there's high exposure to airborne allergens in the first year of life, exposure to tobacco, frequent respiratory infections early in life, low birth weight, and then occupational exposures. So if we look at the mechanism in the hypersensitivity type of asthma, or the atopic type of asthma, so there'd be an inhaled antigen and then activation of your Th2 type of helper T cells. So these are the type of helper T cells that are typically implicated in allergy. The Th2 cells produce cytokines, IL-4 and IL-5 in particular, that will stimulate growth of mast cells, as well as stimulate B cells to react and class switch to produce IgE. IL-5 is another cytokine that can help activate the B cells as well as activating eosinophils. So we see occlusion of the airways by thick mucus, hyperinflation of the lungs. We can see edema as well as patchy epithelial necrosis in some cases. The mucus secretion can result in mucus plugging, and I think you saw a nice example of a mucus plug in the tutorial. Sometimes you may see Kirschmann spirals as well as charcoal-laden crystals, which are associated with the granules that the eosinophils have in their cytoplasm. So an eosinophilic infiltrate is one of the key features that we see in terms of the inflammatory infiltrate. Smooth muscle hypertrophy in the bronchi, and then thickening of the basement membrane. So here, just looking at a normal airway versus an asthmatic airway. And so we see, marked thickening of the bronchial wall due to that smooth muscle hypertrophy and this copious mucus production, just shown here a little bit higher power. So this, obviously causing the airway obstruction. Histologically, in this photomicrograph, we can see hypertrophy of the smooth muscle. In this picture here, it's low power, so it's difficult to appreciate what the actual cellular infiltrate is, but there is some inflammation surrounding this bronchus. Higher power shot showing this thick basement membrane, smooth muscle hypertrophy, and eosinophilic infiltrate. So in this picture here, we're seeing the epithelial layer here, the thick basement membrane here, and then here's the lumen of the bronchus out here. And we're seeing all of these eosinophils, which are basically kind of gummed up in the mucus that's being produced. And we may see Charcot-Leyden crystals. Here's one here, and Kirschmann spirals. So in the non-allergic or non-atopic intrinsic type of asthma, there is considerable overlap with allergic asthma. And in many individuals, there's an increase in serum IgE. So there really is probably a lot of overlap here. Viral infections are often some of the usual suspects or inhaled irritants. The virus may induce mucosal damage, which may trigger asthma. But ultimately, the inflammatory mediators are the same as in the allergy type or the atopic type of asthma, and so the treatment is very similar. So other intrinsic forms of asthma, the drug-induced asthma. So this is basically defined as a pharmacologic agent that's provoking asthma. Aspirin is a common one, and there are some associated features. Recurrent rhinitis and nasal polyps, urticaria and bronchospasm, so all induced by aspirin. And so in this scenario, while the aspirin is inhibiting the cyclooxygenase pathway of arachidonic acid metabolism, it doesn't affect the lipooxygenase pathway, and so you can still get bronchoconstriction that's mediated by the resulting leukotrienes. And so sometimes leukotriene inhibitors can be an effective treatment of asthma. Occupational asthma. So asthma can be stimulated by fumes, organic dusts, chemical dusts, and gases. So epoxy resins and plastics, wood products, cotton, platinum, and toluene. And so the asthma attacks will result following repeated exposures to these agents in susceptible individuals. That was asthma. We're going to finish things off with bronchiectasis. So bronchiectasis is defined as permanent dilation of bronchi, as well as the bronchioles, which is secondary to destruction of the tissue that's supporting them. So the etiology here is obstruction and then resulting chronic and recurrent infections. Bronchial obstruction can be a variety of things, but often foreign body or tumor. There are some congenital conditions that will predispose to bronchiectasis. Cystic fibrosis is a common one, and the obstruction is the very thick mucus that's produced in cystic fibrosis patients, and then they'll have repeated cycles of infection that will eventually result in bronchiectasis. Immunodeficiency states resulting in recurrent infections, and Cartaginer syndrome, which is a congenital abnormality of cilia. And I have one slide at the very end that just sort of gives a few points about Cartaginer syndrome. And then necrotizing or suppurative pneumonias. So usually these are pneumonias that are caused by highly virulent organisms like Staph aureus or species of Klebsiella can cause bronchiectasis due to the tissue destruction that they elicit. So the pathogenesis of bronchiectasis, the first thing is obstruction hampers clearance of mucus and any material that the mucus has trapped. And then secondary infection, usually in those secretions, damaged or weakened bronchial walls because of that infection, and then eventually bronchiectasis. We can see persistent necrotizing infections, obstructive secretions, and subsequent damage. Eventually, these can develop peribronchial and peribronchiolar fibrosis. Once you've got the fibrosis that will occur over recurrent episodes of infection, they'll cause a traction on those large airways, basically pulling them open and dilating them. And that's bronchiectasis. So grossly, we see dilated airways, which can be followed out to the pleural surfaces. So from a practical standpoint, at autopsy, in order to show bronchiectasis, you basically can cut the bronchi down to the very, very distal airways, right out to the pleural surfaces, which you can't do in a normal lung. And on the cut surface of the lung, the dilated bronchi appear almost cyst-like and filled with mucopurulent secretions. So here's bronchiectasis. So in particular, we're looking at this involved portion of the lung, and you can see these markedly dilated large airways. And so you can follow those right out to the pleural surface. So microscopically, what do we see? We see an intense acute and chronic inflammatory exudate in the bronchial walls with necrotizing ulceration of the bronchial epithelium. As a protective mechanism, sometimes the bronchial epithelium will undergo squamous metaplasia because a squamous epithelium can afford a little more protection than the normal columnar epithelium. We may see lung abscesses. So there may be, because of the tissue destruction, you may have formation of an abscess that goes along with that. Fibrosis of the bronchial walls. And usually if you perform microbiological cultures, they'll be positive in bronchiectasis. Okay, I mentioned Cartaginer syndrome. So patients that have a primary disorder of cilia or primary ciliary dyskinesia, which is an autosomal recessive disorder of the ciliary microtubules. So basically, when we talked about the cilia that's normally present in your bronchial mucosa, its job is to sweep out mucus and any entrapped debris that gets into the airways. If the cilia is not working properly, and so if the microtubular network isn't structurally normal, then the cilia is no longer able to do its job or unable to do its job in the first place. And so it will result in persistent infections because you just have stasis of that mucus, which is a good medium for bacteria to grow in. And so eventually, because of these persistent infections, the end result will be bronchiectasis. About half of patients with primary ciliary dyskinesia are Cartaginer syndrome patients. So in these patients, because it's a syndrome, so there are some other manifestations, not only the bronchiectasis in the lungs, but they'll have decreased mobility of spermatozoa because the tails of the sperm can't work properly, and so males are sterile. And then in a third, there's associated congenital abnormality of the chest organs, situs and bursis. Okay, so that's obstructive lung disease. So today we covered restrictive lung disease, obstructive lung disease, and tomorrow we will finish things off with lung neoplasms. I hope to see you then. But before you go, we have to do a clicker question. If you want to do this chord here. Oops. Here's the... Yeah, sorry. I just need to plug that in to the computer. Yeah. If you want to put it up here, you can. I don't know if it reaches or not. But.
Excuse me, ladies and gentlemen, before your professor will comment on the question, I have observed that we have less than 300 of you here, but what we are having here is 422. So which is unfair on the department. We, in as much as we appreciate your coming to the lecture, we cannot tolerate you cheating on others. because it's absolutely cheating if you are clicking for your colleagues. So we are not saying every lecture is compulsory, but please, and please, stop clicking for others that are not here. Because the clickers we are doing, the attendance is very important, and it's also expected that you should have at least a specific amount before the exams. So please take note of that. Thank you.
Okay. Let's just turn this one off. Okay, so the quiz, 36-year-old female being managed for pneumonia in the hospital, develops shortness of breath and hypoxemia, so sudden. It's refractory to oxygen therapy. Chest x-ray shows bilateral pulmonary infiltrates. She died afterwards despite adequate treatment, so that likely would be supportive treatment. Autopsy findings from the lungs shows diffuse alveolar damage and hyaline membranes. So what would we call this disorder? ARDS. So ARDS. So basically, the question is asking what's the potential causes of ARDS. So we have 17% answering chronic pancreatitis. Acute pancreatitis can cause ARDS, but not chronic pancreatitis. Okay, so just remember that. Chronic cigarette smoking. No, not really. There's no association with cigarette smoking and ARDS in particular. Trauma. Yes, trauma is the correct answer here. So trauma is actually a common cause of ARDS. Alpha-1 antitrypsin deficiency, so remember from the lecture today, can give you emphysema, pan-acinar emphysema, but not ARDS. Cartaginer syndrome, not associated in particular with ARDS. Okay, thanks.